Substance use treatment. And I do want to pause just on this slide for a second around the term medication-assisted treatment, which in my view is what it says it is. It is not medication as the treatment. It is medication as a support to the type of treatment that Nora's been talking about and Anderson's been talking about. I think there's a lot of movement around MAT locally and nationally. And I have to say, we then tend to perseverate and focus just on the medicine. And we forget what the medicine is there to actually do. So it's never my favorite thing to be up here and be the pill pusher and the pill, promoter or the injection promoter. So I did want to contextualize that for a moment and say, the reason we put this at the end is because we really wanted to frame up the problems with and the approaches to substance use disorders in terms of the kind of comprehensive treatment with medications as a support to that process. Because we tend to, once we start talking about pills, that's all we talk about. Okay, so Arthur, he's back. So remember Arthur. So when we left him and went to rehab with Anderson, he had a few things going on. Remember, he had concurrent opioid use disorder and alcohol use disorder. He had his pancreatitis and his type 2 diabetes. He was homeless. He was asking me for Ativan for help with his alcohol withdrawal. So when he asked me that, I asked him if he'd ever had withdrawal seizures before, and he said, yeah, but I'm not going to this time. And on exam, he looked slightly inebriated. His vital signs were, as you see, nothing dramatic. His eyes were a little blurry. He didn't have any tremor, and no diaphoresis. He wasn't sweating. Okay, so what would you do with Arthur? Would you help him out with an outpatient detox using chlordiazepoxide or Librium and then see him daily in clinic? Would you go try to do an outpatient detox in your clinic using Gabapentin and seeing him daily? Would you provide him with vouchers for a shelter and arrange for admission tomorrow morning to a local detox? Or would you send him to the emergency department for evaluation and possible admission for alcohol detox? Okay, so I'm really interested in what people think of this. So who would do letter A? Who would do letter B? Who would do letter C? And who would do letter D? Okay, and some people would do nothing, which is always an option in primary care. So the answer is C, or my answer is C, I guess. I guess there are different approaches to this. But so the reason I wanted to talk about this and sort of what we do particularly around the issue with benzodiazepines and patients asking for benzodiazepines for alcohol is I feel like I see this in primary care a fair bit. Patients of mine who've gone to the ED or have gone to urgent care and said, I'm in alcohol withdrawal, and they're sort of given a handful of Librium or Ativan for the road, and they've come to kind of expect that treatment. And I think that's a problem, one, because it could be over-treatment. They don't actually need those benzos, and they're just being used inappropriately. Or it could be under-treatment. It may be that they actually need to have detox in a more supervised setting. So these are criteria from the ASAM Principles of Addiction Medicine of when you want to consider inpatient alcohol detox, or even more, I guess, for us in primary care, detox in a more structured setting. So one is anybody who has a history of withdrawal seizures, that predicts future seizures. It actually lowers their threshold for future seizures, so that's a consideration. The presence of other substance use disorders, so he has concurrent opioid use disorder, we'll often see concurrent methamphetamine use as well. A concurrent medical condition, if somebody's going to need, maybe not their medicines administered to them, but at least have an eye on them for their blood sugar, their blood pressure, whatever it may be. Concurrent behavioral health conditions, particularly serious mental illness may make it, or serious mood disorders even, may make it more difficult to manage detox on an outpatient setting. Lack of a reliable support system or suitable housing. It might be really hard for someone to get sober, and Anderson was talking about this before, if where they live, people are actively drinking, actively using. Also, sometimes care coordination can be really hard, getting somebody from detox to residential to outpatient. That can be really hard on your own, and that's something that a supervised or an inpatient setting can help. And then pregnancy, you definitely want somebody in a more supervised setting. So just something to think about for your patients. So we're going to start out talking about medication efficacy for alcohol use disorder. And my thanks to Melissa and some of her colleagues for this nice summary slide. And this table gives you kind of a high-level summary of the clinical evidence for our four major medications that we use for alcohol use disorder, so which are disulfiram, oral naltrexone, acamprosate, and extended-release naltrexone. And the arrows here just represent the directionality of the effect on these three conditions. So whether those medicines help with abstinence, help with heavy drinking days, help with number of regular drinking days, or help with number of heavy drinking days. And a couple things to notice here is that disulfiram, actually, there are only 2 studies. They're fairly small. This was a medication that was approved before the FDA actually required that you have evidence-based trials. So it's really the one that it's the one that we probably think about and maybe even reach for the most often, but the one which really has the least evidence to support it. And then oral naltrexone, which hasn't been around as long, actually has the most studies to support it. So we're going to go through some of these. First is disulfiram, just because it's the one that we know. As you guys know, probably, it inhibits alcohol dehydrogenase, so that when somebody drinks and they're on this, they don't have the enzyme that helps to metabolize some of the metabolites of alcohol, and you get this disulfiram reaction of flushing and nausea. It's very uncomfortable. It feels to me a little punitive. I mean, I guess I always use the diabetes example. Like if one of my patients ate a candy bar and had diabetes, I wouldn't make them throw up and flush and what have you. But apparently that's one of the ways that we like to approach people who drink. I just kind of gave you some of the basic dosing and monitoring information up there. You do have to monitor LFTs pretty closely. If I'm in the situation where I use this, check them weekly for 4 weeks, then every 2 weeks for 4 weeks, and then still regularly thereafter, because you can see a bump in LFTs even 2-3 months into treatment. It's not something you might see right away. And there have been reports of really acute liver failure on this medication. Okay, so we're going to spend a little bit of time talking about naltrexone as a treatment for alcohol use disorder, because there's been more research on it lately, and it's a pretty interesting medication. So you're wondering, so as we know, naltrexone, we'll talk about this more in a moment, but is an opioid antagonist. It sits on the mu receptor, one of the 3 types of opioid receptors, and therefore blocks reward. Because remember when we showed that diagram of the grand central station of reward, it blocks reward that one may get from endogenous opioids that are released because of alcohol use. The dosing is there, 50 to 100 milligrams. You can start at 25 and titrate it up. And the big study that you want to know related to naltrexone is the COMBINE study, which I have to cheat here and look at my notes, stands for Combining Medications and Behavioral Interventions. And that originally came out in 2006, and studied a lot of people who were given 100 milligrams per day of naltrexone and looked at over the course of 16 weeks. And in the initial look in 2006, it was it was more efficacious in abstinence versus placebo by not a huge margin. It's important to know these numbers of 80.6% to 75.1%, and reduced the risk of heavy drinking days from 66.2% to 73.1%. And then they looked at the data again in 2008 and found that if people were given naltrexone with behavioral therapy and naltrexone without behavioral therapy, they actually had the same outcomes. Take that as you will. Another follow-up study in 2010 showed no sex differences. But then another study in 2010 I thought was really interesting by a woman named Laura Ray, and she looked back at the combined data and sort of hypothesized, okay, so we know that people that this medication is blocking reward. And so if it's blunting the reward, perhaps it's more useful in people who are continuing to drink to get reward while they're on the medication. And she actually found that that was true. She found that individuals who drank more regularly during the 6 weeks of the trial seemed to benefit more from naltrexone, and that became more apparent at months 2 and months 4. So the idea being that if there are people, that there's a small subset of people who may be regular drinkers, and that the naltrexone reduces their number of heavy drinking days. So if you're in an environment, or if you have patients for whom they're in a, sort of more of a regular controlled drinking pattern, and you want to decrease their progression to heavy drinking days, this may be a possibility for them. Does that make sense? Okay. So naltrexone also comes in an injectable form, also known as Vivitrol. So that will block mu receptors for about 4 weeks. And again, similar idea here. It reduces heavy drinking days, a 25% decrease. It is much more costly. This is pretty hard to get approved for alcohol use disorder. It's about $800 to $1,000 per month. If you can work with insurers and say, well, we're doing a cost offset here because this may cause less ER and hospital use, that's one possibility. And then one of the benefits of it also is that adherence is not perfect because people may not get additional injections, but the adherence is much improved if you're doing an injection every 28 days as opposed to taking a pill once a month. Somebody, not the plug in the jug person, but one of the old time recovery people I worked for said it's no longer 1 day at a time, it's 30 days at a time. So a few things to think about as sort of who's the right patient for naltrexone. Again, think about it in terms of a medicine that may be more effective in reducing heavy drinking days as opposed to promoting abstinence. There's also an interesting talk about this working hypothesis that naltrexone may be most effective in people for whom that positive reinforcement, that sort of reward, is the primary motivational driver toward use. It's those people that we saw over on this side of the screen, the folks who are still getting some reward and not those folks whose hedonic set point has gotten lower and lower. I heard one guy say, if you're drinking to get high, this might work. If you're drinking to get numb, this isn't going to work. And don't take that as science, but it's sort of something to think about. There's also been some interesting research in the last 4 or 5 years about pharmacogenetics, and that people with a particular allele of the opioid mu receptor may be more sensitive to naltrexone. So again, not to over-medicalize addictions treatment, but in the future, we may be able to test people for that allele and know that they'll be more responsive to this medication when other people won't. We don't know that now, but it's a possibility. Okay. So the third medication to talk about is acamprosate or Camprol. Its mechanism isn't super well understood, but it's thought to inhibit the action of glutamate, which is an excitatory neurotransmitter, which is upregulated in people with alcohol use disorder, and perhaps interact with the GABA system to help enhance GABA. The dose is a kind of incongruous 666 milligrams 3 times a day. So the data on efficacy is somewhat conflicting. They actually looked in the combined trial as well, looked at acamprosate. It had no effect, but there have been some other meta-analyses that show some improved abstinence rates. Again, when you actually look at the numbers, though, just to be honest, they're not huge. It was, in one meta-analysis, 36.1% versus 23.4% in abstinence. In people with liver disease, you don't need, this is sort of an advantage, particularly over antabuse, you don't need to do dose adjustment, but there are dose adjustments that you may need with more profound hepatic impairment and with renal disease as well, which is up there for your reference. And I just think it's worth mentioning, I won't read all these out loud to you, but there are 3 medications that sort of you hear about most commonly. They're off-label, not FDA approved for alcohol use disorder. One is Topiramate or Topamax, which again antagonizes those glutamate receptors and enhances GABA. Another is Gabapentin. There was a nice article in JAMA in 2013 or so, particularly for Gabapentin's use for some of the more post-acute withdrawal symptoms that you hear people talking about, kind of those son of a bitch, everything is real kind of people. So that a lot of that sense of insomnia, agitation, dysphoria, craving, gabapentin for those symptoms, if titrated up to a dose of about 1,800 milligrams a day was effective. And there's some review articles and evidence look at the use of baclofen as well. So just some things that you may, again, if you're in this boat and people are they're engaging in their program and you're trying different things to support them. Another 3 medications that are perfectly reasonable to try. Okay. So how's Arthur doing? Well, Arthur, he went to inpatient detox. He did well. And during his stay there, he was detoxed from alcohol. He was induced also for his opioid use disorder for buprenorphine, onto buprenorphine and naloxone. And he said, boy, my cravings for opioids are better. Actually, my pain has decreased as well. He had moved from the detox into transitional housing, which allowed him to be on the buprenorphine in the housing. He says, I've reestablished with my AA home group, but I'm actually worried about telling them that I'm on buprenorphine. I don't want them to think that I'm not in real recovery, and I want to know how long I need to be on this. And he'd also heard, he was terrified because he's heard that withdrawal from buprenorphine was worse than heroin. So Arthur has a lot of questions here. I'm going to try to answer some of them as we go through. And these aren't just, this part's made up. Arthur's a real guy. This part about Arthur is not real. But I have to say, when you do talks like this periodically, these are some of the main, people are actually much less interested in the pharmacokinetics of buprenorphine or Vivitrol. People are much more interested in these kind of issues. So, and particularly patients are as well. So I want to make sure that we have some time to sort of think about them, look at some of the evidence around it, but also if you're interested in having some discussion about people's approaches. Okay, so here's another one of these nice summary slides from Melissa and her colleagues. Again, we've got 4 major medications for opioid use disorder. Same idea here with methadone, buprenorphine, oral naltrexone, and then extended release naltrexone. And again, you can see the directionality of effect on 3 major outcomes that are often looked at, which is retention in the program, ongoing opioid misuse, and criminal activity. And some of the references are down there for you. Okay. So saying I wouldn't talk a lot about pharmacokinetics, here we go. So which of the following opioids has the strongest affinity for the mu receptor? Is it morphine, methadone, oxycodone, or buprenorphine? Strongest affinity for the mu opioid. So who thinks A? Who thinks B? Like me. Who thinks C? And D. Good, okay. And they're all good answers. I don't know, I just learned this when I was reading up on this for this talk. So yes, you're right, it's buprenorphine. And here's a table that tries to give you a sense, and if this bores you, that's totally, I guess I didn't think it bored you. You can tune out, but this will help when we understand how buprenorphine works. So this is an idea of receptor affinity versus activation. So affinity is how tightly something binds to a receptor. And it's measured by that a binding constant, sort of the kappa constant. And the idea is that the lower the constant, the higher that affinity. So buprenorphine is actually, of all opioids, partial agonist or full agonist is one opioid that binds most tightly to the opioid receptor, on the order with hydromorphone. And some forms of fentanyl. And other medications, other types of fentanyl, morphine, and methadone actually bind less tightly. Naloxone, whose binding constant I don't have, binds with about the same affinity as buprenorphine, and sufentanil does. And this will come, the reason I bring this up, it'll come up in a minute when we talk about sort of the use and the administration of buprenorphine. So know, though, that receptor binding strength is not the same as receptor activation. So here's a nice diagram that gives you a sense of receptor activation. So on the, what's this one? The x-axis gives you tells you how much of a medication is being given, and the y-axis is its level of activity or activation, how high. And you can see at the very bottom there, naltrexone, which is an opioid antagonist, you can give as much of that dose as you want, and you get 0 receptor activity. A full agonist, like methadone, shows as you increase the dose, you get, not exactly a linear, but you get sort of logarithmic effect around, increased dose means increased activity, until you reach a ceiling effect, which one anesthesiologist pointed out to me is called death. I guess that's not very funny. And then there's a partial agonist like buprenorphine, which we know binds very tightly, has very high affinity, but actually only activates that receptor a certain degree. So you give a certain dose, and for a while it's sort of that the dose increase is mirroring what methadone does in terms of receptor activity, but at a certain point you get to a dose where you get to a level where no matter how much of the dose you give, you're going to get the same level of receptor activity. And again, this will help us a little bit more in understanding these. So we're basically now in the next few minutes, we're going to go through each of these and kind of how they work in people with opioid use disorder. Okay. So first is methadone, which as we just looked at is a full agonist. If you're going to give methadone, you probably know this, but if you're going to give methadone for the treatment of opioid use disorder, you don't do that in a primary care clinic. It needs to be done in a federally qualified methadone clinic or what we call an opioid treatment program. So this is a full agonist with a long elimination half-life. It takes a while for it to get out of one's body. And in the methadone clinic, medication is dispensed daily, either by an RN or by an LPN. And what the methadone does is to reduce the euphoria of subsequent opioid use and sort of saturate opioid receptors also without making people feel euphoric or loaded or high. It's effective in increasing retention and treatment, reducing use of opioids, reducing HIV, a number of other outcomes. The typical dose range is about 60 to 90 milligrams per day. Lower doses below 20 milligrams or so have been shown to not be as effective. It's the treatment of choice for pregnant women. And the nice thing about the opioid treatment programs is it really has integrated individual and group counseling as part of the program. So people are attending groups of many different types, like the ones that Anderson was telling us about, and also having individual meetings with their counselor. Some of the downsides of methadone, it has a lot of drug-drug interactions, particularly with anticonvulsants, with other HIV meds, with rifampin. I'll never forget as a rookie primary care provider, the first time I gave rifampin to a patient on methadone, and they just never spoke to me again. It just rapidly metabolized all of their methadone, so I made that mistake once. It also causes can cause pronounced QTc prolongation, which is a cardiac side effect, particularly in combination with other medications. So you have to be pretty careful. This is we'll get to this in a second, but it's a care coordination piece. You have to sort of know that they're on methadone if you're also prescribing particularly things like tricyclics, which can also increase their QTc. I'm sorry, yeah.
I'm sorry, this might be a stupid question, but the typical effective dose range, aren't those the numbers we were talking about being way too high for the MEQs? And you said that 20 milligrams a day isn't effective.
Right. So again, this is in a much more structured and supervised setting. So in the purposes of an opioid treatment program, in order to be able to, for some people, adequately saturate their opioid receptors, you need higher doses. But it's not in a setting where somebody is taking it 3-4 times a day, they're taking it at home, they're not being monitored, you know what I mean? So within the structure of an opioid, this is why it's only in this setting, within the structure of this setting. And when you look at overdose, like when you look at opioid overdose rates within Oregon, for instance, and you look at methadone overdose rates, they've gone up like 1,500% within a particular period of time, and none of those, or very few of those, were within the context of an opioid treatment program. This is also a place where you can monitor for concurrent medications that people are taking, if they're also taking benzodiazepines or muscle relaxers, other things that are going to potentiate and increase their risk of overdose.
But so those patients actually do have to be on the outside of the guidelines that we're talking about.
Yeah, and that's really around pain management, again, in a much different, less structured, less monitored setting. And it gets confusing, but much of the overdoses that we see also on prescription opioids for pain, 50 to 60% of the time, they're in the context of other medications that people are using. Muscle relaxers, benzodiazepines, sleep aids, things like that, which is part of the lethality. Okay. Okay, so then we'll pivot for a second, talk about buprenorphine. So as we talked about, it's a partial agonist, and the nice thing about the place where buprenorphine's ceiling effect hits, is that it hits at the level, it reaches its ceiling effect below the level where the opioids have shut down your drive to breathe. And this is why it's a relatively safer medication and one that can be prescribed then because of that sort of larger therapeutic window in a primary care setting. And the way it works is, the thing that's tricky about it often is how it gets administered. So this is just a little cartoon to show you buprenorphine is those little dots, the little yellow dots, and then a full agonist like morphine, say, is the green guy. And a full agonist will go and sit perfectly, like morphine, on that receptor, in a perfect fit, and you get a maximal opioid effect. But then if buprenorphine comes along, because, as we talked about it, because it has such a high affinity for that opioid receptor, even if it doesn't have as high of an activation, it's going to bump off those morphine molecules, and that might actually precipitate a sort of rapid withdrawal of a full agonist with a partial agonist may precipitate a pretty profound withdrawal effect in the patient. And so that's why sometimes the induction onto buprenorphine can be a little tricky, and you have to make sure the person doesn't have any or very little other opioids in their system so that you don't precipitate this withdrawal when you start the medicine. But you get training to do this. So buprenorphine itself is often combined with naloxone as an abuse deterrent, and those two together are called Suboxone. And this is just kind of a busy slide with a lot of information on it, which I won't read to you too much. But the idea of having buprenorphine naloxone, and what the Drug Abuse Treatment Act in 2000 recognized, is that for some people they need a lower barrier to addiction treatment, or need a different setting other than an opioid treatment program to get their addiction treatment. And that's where Suboxone can come in. It can be used in primary care, it can be used in a specialty outpatient addiction setting, it can be used in a residential setting, but this idea is that it's kind of more office-based opioid replacement. You do need to have extra training, 8 hours of training to get your DEA waiver, and currently, although HHS and SAMHSA are looking at this, the current guidelines are that you can treat 30 patients in your first year and then up to 100 patients. And again, the naloxone in it serves as an abuse deterrent. Similar efficacy to methadone at medium and high doses. There's a few other studies that are worth looking at. There's a number of studies that look at buprenorphine for pain. It originally is a pain medication, but as for people with concurrent pain and opioid use disorder, a number of studies which show it's effective for both of those things. It has fewer drug-drug interactions and less QTC prolongation than methadone. And then this is a piece, the kappa antagonism, which we don't talk about much, but is really an important, I think, kind of underreported effect of Suboxone. So we talked about dynorphin earlier, one of those one of the anti-reward neurotransmitters that's upregulated in sort of sustained addiction. Well, dynorphin is actually in the opioid family and acts on the kappa receptor, which is one of the 3 types of opioid receptors. And buprenorphine antagonizes that kappa receptor. So all that dynorphin that's swimming around and making you feel dysphoric is actually being antagonized by buprenorphine as well. And so buprenorphine, in some senses, can serve in kind of an antidepressant capacity. Sometimes you find you taper people off of their buprenorphine. They're doing okay with their opioid cravings, but you actually need to then treat their depression. So again, a nice feature of it. So a question I hear a lot is sort of, why would you choose one or the other? Why would you have someone on buprenorphine or methadone? Why would you have someone in a methadone clinic, in an opioid treatment program, or in an office-based, or what we call an OBOT setting? So this is just a little table that might try to help you weigh these comparisons with patients. So first, in an opioid treatment program, you have the option of methadone, and in some clinics, you have the option of buprenorphine as well, so you can do both. If somebody's in an OBOT setting, you only have the option of giving them buprenorphine. The big one, and I think probably the most reason that people choose one or the other, is I think of a OTP as it's more care, right? It's like sending your patient with congestive heart failure to the cardiologist because you can't really manage it in the primary care setting anymore. They need more attention to their medication titration. They might need higher studies. It's the same idea in a methadone clinic. They're getting more daily dispense, more nursing contact, more eyes on, more touches with a counselor. And that might be more amenable for people, let's say, who have polysubstance use, or who are homeless and have unstable housing and don't have a safe place to store their medication, or are going home every day and everybody around them is using. So that's a distinction that we use a lot. In an opioid treatment program, there's much more structured and integrated counseling that's kind of built into the program. In an OBOT setting, you may have to refer out for counseling in a primary care setting, or within the confines of a primary care clinic, you can provide level 1 counseling. We have some folks here from Central City who can tell you all about that. On the other hand, in an opioid treatment program, there's a lot of barriers to care coordination with primary care. There are a lot of confidentiality and privacy rules that you need to follow closely. Sometimes patients don't want to disclose to primary care that they're on methadone. So both through stigma and through legislation and just through time constraints, there's a lot of issues around care coordination. And in an OBOT setting, if you're doing it in primary care, you're already integrating. In opioid treatment program, if you want to split out the dosing to help, let's say, with pain management, because pain is better managed if the methadone is split out, that actually takes some approval in an opioid treatment program, and it's more easily and readily done in the OBOT setting. And finally is around payment. We actually have a payment model. I take care of Medicaid patients and Medicare patients, at least a Medicaid model that nicely supports integrated care within the OTP setting. It's a little more difficult, I shouldn't have said no payment, but more difficult to get payment for integrated counseling and medication within a primary care setting. So just some things that patients are asking you or colleagues are asking you, which one of these, just a few guidelines to go on there. Okay, so Arthur also wanted to know if this was real recovery. Right, I'm on this medication. I don't want to tell anybody I'm on it because in my AA group, because I'm worried it's real recovery. And in my view, real recovery is the one that works for you. So, and for some people that may be without medication. This is a study that looked at the use of buprenorphine versus not using buprenorphine. So this was a Swedish study of just middle-class heroin users in Sweden. And they looked at the efficacy of buprenorphine combined with intensive psychosocial counseling compared to people who got only the intensive psychosocial counseling. The latter group, I think, had a 7-day detox taper from buprenorphine and then received only counseling, and the other folks received maintenance dosing. And the outcomes are pretty marked here, that after 1 year, nobody in the placebo group, placebo plus counseling, was still in remission, whereas about 75% were still abstinent. Again, this is one study, take it as you will, but when people say, is this real recovery, I say, well, for a sizable portion of people, it's working really well. Okay, Arthur's also really concerned about withdrawal. He's worried about coming off of this medication. So question for you, withdrawal from buprenorphine is it less severe than heroin withdrawal? Is it more severe than methadone withdrawal? Is it both of the above? Or is it none of the above? Okay, so who thinks it's A? Okay. Who thinks it's B? Who thinks it's C? Okay. And who thinks D? Okay. So it's A. So it is less severe than heroin withdrawal. I'm not good at these both and. But this one I think is right. Okay, so this is a study in the New England Journal that I should have gone back and read it before doing this. I'm not exactly sure how they decided to abruptly discontinue people from these 3 different types of opioids, but it happened. And then they looked at their withdrawal symptoms with a variety of scales over the next 15 days. So you can see that the most pronounced withdrawal symptoms that you get are with heroin, and the most protracted withdrawal symptoms that you get are with methadone, but that buprenorphine actually is less intense than heroin withdrawal and is less intense and actually briefer than methadone withdrawal. And you'll hear, and again, you'll always hear different things from different people, but this is one study that gives you at least some quantitative objective to look at. Okay, just want to talk briefly also, it's funny also, I was just at before coming here, I wasn't at the Senator Wyden thing, but I was at a policy briefing beforehand, and there was a lot of discussion around, diversion of buprenorphine and concern about it, and some guy from the DEA and the high-intensity drug trafficking areas saying, every time there's a heroin bust, there's also a buprenorphine bust. So not to get into that topic, but the idea being that around medication-assisted treatment, we often focus a lot on buprenorphine, which people have concerns about diversion with or misuse. And one nice option then, where we have much less concern about abuse and diversion, is using naltrexone for opioid use disorder. So just to not forget about it. We often don't talk about it as much because really the extended release form, as we said, is really expensive, but it's a great alternative. And the idea, as we talked about before, it's an opioid antagonist, and this idea that if you sort of an extinction paradigm, that your cravings will cease if the pleasurable effects are blocked. And I've just heard patients say, well, why would I use if I know it's not going to work? I think the other thing that's been interesting, though, about naltrexone is that idea of incentive salience that we talked about, that kind of cue-induced craving. When you block their reward receptors, that desiring and that wanting, that sense of seeing a visual cue goes away, can go away. I had one patient tell me, she said, yeah, she was on Vivitrol, and she said, I was with some friends and they were shooting up, and I was like, why were you doing that in the first place? So I didn't take that any further. And she said, and I didn't even feel triggered by that, as opposed to some other data that we've heard where it actually does. So that's another interesting side effect, or interesting effect of it. Another thing, it's not a controlled substance, so anybody who is a prescriber can prescribe. You don't need additional training as you do with buprenorphine. Again, there's sort of an oral version, an extended release version. The oral version really has lower retention, and then there really is that risk of overdose if somebody relapses. If they've been taking their oral naltrexone every day for 7 days, let's say 10 days, and then decide to take a day off and use, their tolerance is going to be much lower, and the risk of overdose is higher. So we really try to encourage our payers to support the extended release formulation. And I apologize, I didn't put the studies up there. I'll give them to you, but a couple of major studies which show increase in treatment retention and decrease in opioid use. It is worth noting that there aren't any direct comparison head-to-head trials between Vivitrol and the agonist therapies like buprenorphine or methadone. So if you want to try to compare the two in terms of efficacy, that hasn't been done. All right, so Arthur's last question, he's like, how long should I stay on this? And this is another really hard question that people ask. And it's easy to jump to sort of medical analogies of like, I don't know, how long should you stay on your Lipitor? But it is something, I think it's worth recognizing, that is fraught with other kinds of kind of emotional and social pressures. So we can turn to the data and say, what do we know about people when they taper off of MAT? And it's not that robust, but I just wanted to give you a couple studies that I found. One, this was a study by Walter Ling, who's down at UCLA. He's kind of the godfather of buprenorphine. And he was actually studying, when you do taper, how long should the taper be? So he had about 500. This wasn't a study intended to show the effects of tapering altogether, but just to figure out if you are going to taper, how long would that taper be? But the effects were still pretty startling. So we had people who were in a 4-week stabilization phase of buprenorphine, and then compared them if they were on a 7-day taper or a 28-day taper. 7-day taper versus 28 taper, there wasn't any difference. But what's pretty profound is that the relapse rates were around 87-88% 3 months later after those tapers. For people with prescription opioid use disorder, Dr. Weiss at Yale did a study looking at patients who are on buprenorphine for prescription opioid use disorder. And she had 2 groups, and I got to cheat and look at my notes because I won't remember otherwise. But group 1 was sort of on a 2-week stabilization and then a 2-week taper, and then they were followed up 8 weeks later. And if they were successful, they were done. And if they were unsuccessful, meaning if they had relapsed, they were then put into group 2, where they then got 12 weeks of another 12 weeks of treatment and another 4-week taper, and then an 8-week follow-up. And what was striking is that in both groups, the relapse rate was over 90%. So again, do I tell patients, no, you can't ever go off of this? You do give the advice, though, that relapse is common, and so what do you do? Well, that black hole that I put up there, 1 is sort of pretty, and 2 is a reminder to myself to tell you kind of my favorite analogy that I heard once about the use of medication-assisted treatment or buprenorphine and addiction. And this guy said, addiction's like a black hole. It's like, it's got this giant sort of gravitational pull coming towards you. And what the buprenorphine does, or the medication does, is allow you to get far away enough from that gravitational pull to then start working on everything else, on all the stuff that Anderson was talking about, to allow you to run away as far as you can. So that then in the event that you decide to go off that medication, you're further out from that gravitational pull. And I think that's, to me, is a good, if somebody chooses to be on medication and chooses to taper off, to ensure we're not just cutting this off because of a particular time limit, and it's probably, if you haven't been working other parts of your recovery program, that's also probably a reason that we don't want to take you off now. Okay, and then you can't talk about any kind of medication-assisted treatment without talking about naloxone. And this was, when I first started talking about this stuff a few years ago, this was a bigger deal. Naloxone's obviously got much more coverage, both in terms of insurance and press and ability of other people to prescribe. But the concept for people like lay people who aren't anybody to get a naloxone kit, which is now you can do in Oregon, is that overdose is usually witnessed. Death usually takes a while in the case of an overdose, so there's an opportunity to intervene. This is different with some of the fentanyl that we're seeing now, where the overdose happens much more quickly. But with other opioids, the death takes a while. People don't routinely access emergency medical services, particularly if there's not a Good Samaritan law in place, which we actually have in Oregon. So having a friend who has a naloxone kit is helpful. Naloxone's safe and effective if you use it on someone who's not overdosing. The effects are negligible. And actually, if you rapidly reverse somebody with naloxone, and let's say then they go to the emergency department or they end up in the ICU, their outcomes in that hospitalization are better. So a friend of mine from San Francisco said, just think of it like an AED. So that's just a few resources for you. I just want to point out that the Oregon Pain Guidance folks in Southern Oregon have this terrific website, and the state has actually now sponsored a group of clinicians to build out provider and patient education on that OPG website. And so we're sort of in the process of doing that over the next 6 to 12 months. But it'll be more of a central place where you can go for information about lots of the things that we've talked about today. And then there are a number of other resources up there for your review. And that's it. Do you want to just do questions with everyone? Okay, so we can do questions, I think just with we had the idea of there's questions for us, but then if we wanted to do questions with the large group, we can just do that now. So we can open it up for questions, and we can have questions for me and Anderson for this piece, or we can invite others up and we can do questions about anything else for the day as well. Sure, I can turn this off. Thomas has a question.
How about buprenorphine for chronic pain conditions? How effective is that?
Would you like to answer? Yeah.
Is that a good question?
Yeah. Yes.
Okay. And then the other question I had was about marijuana.
Yep.
So how many physicians or prescribers do we have in the audience? Yeah, okay, good. You guys are diehards. So how many of you have been are aware of, so we talked about buprenorphine in terms of Suboxone. It used to be that we didn't have buprenorphine kind of outside of that for chronic pain conditions until fairly recently. The first product that came out was called the Butrans patch. So how many people are aware of the Butrans patch, what that is and how that works? Good. It seems like that's pretty popular. It seems like to be a fairly kind of low risk opioid for long-term for folks for whom being off an opioid for their chronic pain is not a possibility, at least not at the moment. The biggest problem with buprenorphine from the patch is, at least in my experience, it has actually been has been a rash. The other big problem is transitioning someone from a lot of short-acting opioid to the Butrans patch. That often doesn't go super smoothly, so just use some caution there. And then, is anyone aware of the the new FDA buprenorphine for chronic pain called Belbuca? Has anyone used that? No. So that came out in February. It comes in very small doses, everything from 75 micrograms all the way up to 900 micrograms. The Suboxone Subutex tends to come in 2 to 8 milligrams for Subutex and 2, 4, 6, 8, I think 12 milligrams for Suboxone. So we are seeing, and you probably will see, at least in your practices, more buprenorphine for the indication of chronic pain conditions. Thanks for letting me answer that. That was amazing. I know.
What a good answer.
Unfortunately, there aren't really any great studies about buprenorphine for this population, though, and I think there needs to be more RCTs to actually see if it's patients who taper off of high doses to transition to buprenorphine, how they do, how's their pain control, how's their quality of life, those sorts of things. We wrote a PCORI grant at OHSU that maybe will get funded, and if it does, it'll be the largest RCT to look at that. So hopefully that'll get funded.
Anything about low-dose naltrexone on your radar?
It just kind of comes in and out of favor.
Low-dose naltrexone.
So low-dose naltrexone for pain. They're especially for complex patients. So if you looked at the naltrexone doses orally, they were 50 to 100 milligrams. When we talk about low-dose naltrexone, we're usually talking about 5 milligrams or something in that range at night, typically. And so has anybody used that for chronic complex or persistent complex pain? I actually only do it when patients ask me to try it because they've read an article. And there's absolutely usually, is there a contraindication to trying it? Other than cost, it has to be. Well, yeah, being on opioids. But it has to be compounded. So it sometimes comes in a liquid, or you can have them compounded into a tablet. And it's low risk and worth a try. So I think about it, but I don't generally go to it.
It has something to do with the excitation of the toll-like receptor, which we're starting to know more and more about how that affects pain. But I've used it successfully in 2 patients thus far, patients who were very averse to opioids and didn't really feel like there were any other options. And it wasn't like a miracle drug, but it did help them a bit. But we're just learning more about it. The higher doses are not necessary, though. You could compound it yourself, but you'd have to take a 25 milligram tablet, crush it, make a slurry, and then give it to yourself. So that could be prohibitive if you have to pay for it out of pocket for compounding.
I got one. How do you determine the dose of Suboxone? Do you go by client self-report? Do you go by the duration of their opiate history, the amounts they used? I haven't used in 2 years, but I need to be on Suboxone, or I've been on opiates for 10 years. Not continuously, but shipping every now and then, and I've overdosed 3 times. How do you determine 8 milligrams, 16, or 24? Is there clinical evidence, or is it more like client self-report I'm filling off? And what's best?
Are you talking in the context of pain or?
In the context of preventing going back to illegal or illicit opiates?
I'll tell you what I do, and other people can jump in. I mean, particularly for people who are already taking or actively using heroin or on moderate doses of opioids, we do home inductions, as you know, and so the guidelines are generally that you start with 4 milligrams, when they're in suitable withdrawal, and then they can take up to, some people say 8, some people say 12. I usually stick around 8 on the first day, and then take the total amount from that day, the following morning, and then they sort of have a titration schedule. I tend to call people. There's protocols where you can have nurses call people as well, and you ask them how you're doing, and they're saying, well, I'm still having cravings. And then you say, okay, then why don't you take another 4 milligrams or so? So you titrate them up depending on what their cravings are until they reach a maintenance dose. The data above 24 milligrams, at least I heard one anesthesiologist talk about there is no ceiling limit for the analgesic effect. I haven't pushed it beyond that, but for suppressing withdrawal and cravings, usually the ceiling limit is around 24 milligrams. And you tell people beyond that, you're just we're wasting our money. For people who are on lower doses of opioids, let's say, or not using, you can start at, you can do that same process, but start at lower doses, let's say 2 milligrams. I even have one patient, she figured out how to get herself to 1 milligram from she's just very cautious about it. But it's usually titrated to effect, again, to that ceiling dose of 24.
Can I expand on the pain side of that? Because I want to know who the anesthesia was. It me? I didn't say that for pain.
No. There's this woman, Andrea Rubenstein from Kaiser.
Well, so in my experience, what I find is that folks who are taking buprenorphine for pain sometimes ramp up a lot. So I start just like Rachel was talking about for chronic pain. And these are people who've been on high doses of opioids, by the way, so I'm not talking about opioid-naive patients. And I can see them ramp up, often into the 24, 32 milligram dosage. And almost invariably, anybody who's done that has done poorly. Like, it doesn't help their pain. They want to get off of it. And so then I talk about a taper. And almost invariably, as they taper down, they find a dose between typically 4 to 12 milligrams or 16 milligrams, and they say, this is actually working pretty well. It generally takes somewhere around 4 to 6 weeks in that time frame. And I'll when I start it with patients, I'll tell them, hey, you might find a honeymoon period here, but this is like all medicines for chronic pain or persistent pain. They just are part of a treatment program. It's as a solo, I don't recommend it. But I don't have any data or studies to back that up.
I just had a question about this kind of the synergistic medications with buprenorphine. Like I know alcohol and benzos are being known as a methadone. Is there that same risk with buprenorphine too? So it's not like buprenorphine is some safe thing for people that are drinking to be on if they have an opioid problem too.
Yeah, the risks around respiratory depression, and in the event of adverse events with buprenorphine, it's by and large in combination with other CNS acting medications or drugs.
Yeah.
So they aren't supposed to be drinking on Suboxone or on methadone, are they?
Yeah, no, they're both opioids, so alcohol and opioids don't.
Okay.
Yeah, how about marijuana?
Perspective for marijuana. Should they be using marijuana if they're on methadone? Was that the question?
Yeah, for pain or in the substance use disorder group.
Well, drinking and pain is not a good combination. Drinking alcohol actually increases your pain sensitivity, really reduces your ability for your brain to recover, to get restful sleep. Alcohol should be avoided in persistent pain conditions, kind of period.
And really, to have analgesic effect with alcohol, you have to drink a lot. I mean, that's why they used to, have it and
Like a fit?
before surgery in the days before we had anesthesia, it's just like give people a bunch of whiskey. But anyway, to answer the question about marijuana and methadone, so if you're in a methadone maintenance program, so an opioid treatment program, different programs have different stances. I can tell you the stance at CODA, and I can tell you the stance at another more liberal treatment program around marijuana. So at CODA, we approve marijuana for conditions that are evidence-based, such as HIV wasting or nausea, vomiting due to chemotherapy. And before I became the medical director at CODA, I didn't think that there were a lot of sick people on methadone. I don't know. I just didn't really realize that we have a whole population of people who are really, really incredibly ill, and they get the majority of their treatment at a methadone maintenance program. And I didn't realize that a lot of my work at a methadone maintenance program would actually be coordinating care for really sick patients who are dying of things like testicular cancer and God knows what. I mean, all kinds of just really, really difficult illnesses. So anyway, we do have a fair number of patients who fit that category, and what that means is that they would be eligible for take-homes or takeouts if they have those conditions and they're using marijuana for that medicinal purpose. If they don't have those conditions and they're using marijuana, our across-the-board stance is that we can't sort of monitor it and ensure that it hasn't potentially developed, they haven't potentially developed a substance use disorder to marijuana, and therefore we have just across the board said you're not eligible for takeouts if you are continuing use to marijuana and you don't have those conditions. That being said, there are treatment programs in Washington State in particular that don't even test for marijuana, because they just said, you know what, we don't even care. We don't care if you use marijuana. It's fine. We just don't want to know. I don't necessarily think I can understand them being a bit more liberal, but I do see a fair number of patients having harms due to marijuana, so I don't think we should just completely ignore it. It would sort of be like ignoring alcohol, never checking for alcohol because it's legal, though their stance is that it's a much safer substance than alcohol. In regard to marijuana and pain, that's a tricky conversation for patients. I can tell you where I sit professionally with this issue right now is that the majority of my patients who have chronic pain, I have not found marijuana to be hugely helpful to them improving their quality of life. That's sort of, in general, that's what I've seen. There are patients, and there may be 2 or 3 patients I've seen who actually have benefited from marijuana, but they're not prescribed opioids. They're using very small amounts of marijuana. We've talked about it. I've sent them to a reputable clinic. They've seen a doctor who's actually kind of worked with them to find marijuana that's suitable, and they understand the risks, and we've had a fully informed conversation about it. And they have benefited, and they're not using opioids. They're functional, they're exercising, they're working, they're doing well. The flip side is the patient who's on opioids, not doing well, sedentary, obese, not finding benefit from any therapies, not engaged in physical therapy, and they're wanting to use marijuana medicinally, but they're also falling asleep in my clinic, and they're, not engaged in physical therapy and what have you. So for those patients, or any patients prescribed opioids in our clinic, we've taken the stance that we don't allow concomitant use if you're prescribed opioids, despite it being legal. I do have some patients who will say, well, maybe I'll use marijuana to help me get off of opioids. And, I don't necessarily think it's a miracle or it's going to necessarily totally help them. So I might say you could try that once or twice and see if it helps you. But again, I kind of talk to them about the narrow therapeutic window with marijuana. I talk about using marijuana to help you be more functional as opposed to not functional. So if it's just making you sit and not do anything, that's absolutely not the purpose of a pain treatment. So those are some of the general principles that I'm utilizing. I'm happy to let other people talk about their approach. And I know it's a controversial topic, so.
No, I mean, I think you covered it really well. I mean, there's a lot of interest in cannabinoids and their use as analgesics, and I think that you will start to see more products like the Butrans patch coming out. You may see cannabinoid patches of one form or another. We're already seeing like CBD, topicals coming out. I have a group of like 80 to 90-year-olds who can't tolerate a whiff of anything, and they decide to use topical CBD, and they're doing wonderful. And you know how many times I see them back in my office? 0. Like they don't come back. But outside of that, they what you said, Melissa, was if it does help, it's not a lot. And there's often other things that we need to work on. I know SAFE, Workman's Comp, Multnomah County, and I think many of the other county health clinics have said you can use marijuana or you can use opioids for pain, but we're not going to do both. And that's true in the legacy system as well. Although there's a lot of variability, and in my own practice, there's a lot of variability. I try not to get too stuck on substances, but more on function and how do we improve that. The cannabinoid system is different than the opioid system. You can't just stop an opioid and use, cannabinoids to replace it. You'll still go through this terrible withdrawal syndrome that can be treated with things like clonidine and anti-nausea medicines and so forth. But yeah, does that help at all?
Yeah, and then Suboxone treatment doesn't always require all the drug testing stuff, so then marijuana use might not come up as much. But would the recommendation also be kind of don't use those at the same time, really? Or?
You mean like Suboxone and cannabinoids?
So when we, you can ask everybody at your table there, but when we use Suboxone for opioid use disorder, we do test randomly and regularly in the same way. Yeah.
We still test when you, yeah. When I prescribe Suboxone, I do. Yeah. I mean, the question is always, how does this help your function? In what way are we moving towards health? And it's typically a discussion around that. And some people, it seems like it's useful, and in other patients, not so useful. The younger you are, the more likely it's not going to be all that helpful.
So we're a little after 4 here, and the crowds are thinning, but thank you so much for staying through till the end. Appreciate everybody, all of our wonderful planning folks and Christine. We'll be in touch.